Some of the places I liked the best that were the friendliest, and there are places in West Virginia and Canada and Vietnam, but Findlay, Ohio, you're in the top 100, the top 5. So it's actually an honor to be here. I appreciate the offer, and I'd like to, is that Mike back there? I want to say something about my friend Mike Flaherty. We've been friends for decades, and we've worked together on many projects, and I've been around the country. I've been on part of the Clinical Trials Network. I know the head of NIDA. I have colleagues at Harvard, Yale, Johns Hopkins, all the creme de la creme. So I know a lot of people, including Dr. Tarter, who are very smart and know a lot. Nobody knows addiction as broadly as Dr. Flaherty. He's amazing. So I think he deserves a big round of applause. He's trying to get me to act Irish. I'm Irish, and I don't even know when St. Patrick's Day is. So he's trying to change that. So a couple caveats. One is I'm taking some medicine, so I'm a little dry, and I'll be drinking a little bit, but maybe it's nerves after following Dr. Tarter. How many of you would like to follow Dr. Tarter? And the other thing is I'm a little heavy in the heart because I realized my daughter sent me a note. It was 15 years ago today I buried my wife of 30 years who had died of cancer. So I'll try to compartmentalize and not think much about that, but when I do, it kind of freaks me out. So just please bear with me. Oh, there's some breaking news. Penn State, 63. Ohio State, 14. Who's Ohio State fans? I'm sorry to break the news to you. You remember the year? Who remembers the year? 1994. So people like me and Mike live in the past. All right, so let's get started here. So this is the agenda. I may not get to everything because of time, but we want to focus on helping families and doing things that make a difference. And what I'll stress throughout the morning is there are many ways in which we can affect family. Clinically is just one, but there are many other ways as well. And if I have time, I want to talk a little bit about grief, because that's a big issue with families. So this is based on a lot of different factors. No one factor, the literature. There's a significant science on the efficacy of family interventions in terms of engagement and in terms of treatment. But the problem is they're not used that much. So that's something we have to think about. And I'll share some of my personal experiences and some of my observations because I have some strong opinions about where the field is. So, but what's important today is what are the current gaps in services for families that your organization can address. So if you would take a minute at your table and just share your idea about one gap in service. If each of you could just take a moment or two. No extensive discussion, just give your opinion quickly. Okay? Okay, let me have your attention. So let me get just 2 or 3 examples and just speak loudly. Can I have 2 or 3 examples? Anyone?
Housing.
I'm sorry? Housing, okay. When you get my age, you have, your hearing goes, but your sex appetite doubles. So you go from sex once a year to twice a year. So there's some good things about getting older. So you're talking about housing for the people with the addiction? Okay, how about some other gaps in services?
Grandparents raising their grandchildren.
Oh, that's amazing. Grandparents raising their grandchildren. Amazing. I have 8 grandkids. I love them. I love them. We have a great time. And one of my favorite times is, goodbye. I'll see you next time. And a lot of us know grandparents who are taking care of children. I have one friend, she's taking care of a 11, 9, and 8-year-old. They all have severe mental health problems. because the mother has a severe addiction and her partner has a severe addiction as well, although the children have 3 different fathers, all of whom had addictions. And she's in her 60s, and that's not her idea of retirement. And I would take care of my grandkids, but that's not my idea of retirement as well. So we don't focus enough. I would even take it further. We don't focus enough on parents. So anything you could do to help parents and grandparents is a significant contribution. So let's get one other example. Transportation, okay. And how about one other one related maybe to clinical services or support programs?
Male peer mentors.
What about male peer mentors? Not enough male peer mentors, yeah. Well, the other thing, too, is if you look at some of the mutual support programs, like a program like Al-Anon, the attendance is much more women than men. And we need more men to get involved in mutual support and treatment. So there are a lot of gaps, and if you can go away today with one idea to do something different, that's a good thing. So what are some of the trends? These are some of the trends, and I won't go over all these because you're probably familiar with some of the details. But what I want to focus on the left side, are 2 issues. Low treatment entry rates. And we should be ashamed, I'm not saying you guys, but our culture, in that only about 11% of people with substance use disorders get addiction treatment. Now, some get treatment in medical systems, which is good. We're getting better. But how many people with diabetes or cancer get treatment? Or schizophrenia? Or major depressive illness? It's much higher. We have low rates of treatment entry. And if you don't get the family involved, those rates will stay low. The family is important, and we're talking about concerned significant others as well, getting people in treatment. When they are involved, and there's good evidence of this, the increase in treatment entry is very significant. It goes way, way up. So the family is important in helping people who have substance use disorders get help. And then the second point in bold is we have limited family services, staff education, and training. We did a survey last year of about 100 clinicians in the community, and they endorse kind of moderate knowledge of the family, but most of them don't know much about family interventions, the evidence-based family interventions. So if you ask about, do you know about the CRAFT model? Maybe 5 or 7%. So we need to educate staff, and we need to do a better job of training them to do family interventions. Now, the good news, want to hear the good news? The good news is there's a lot of good options for people in recovery. There's a lot of different pathways, which I'll talk about shortly. I think 2 major things. Mike had mentioned our group at Western Psych was one of the first in the country to focus on co-occurring psychiatric disorders and addiction. You know, we did this back in the 80s when the movement started. So more people are getting integrated care. Those of you who work in medical systems, what's important now is integrated care of behavioral health, whether it be depression, substance use, and physical health. We need to do a better job integrating our care. So that's a challenge, but it can be done. We're doing more of that. Another point, I think, is that peers, how many of you have peers in recovery on your staff? How many of these are family peers? So that's something you may want to think about as well, get more families in recovery to participate in what you do. And then the other thing is, look at the last point, high rates of recovery. And that is from the Harvard study a couple years ago. Now, when you hear, what do you hear on the news? Do you hear about Mike's in recovery and doing well? What do you hear? You hear this woman who overdosed in Kmart parking lot or Sam's Club parking lot. But we have high rates of recovery. We have high rates of people doing well who stick with treatment. And we need to convey that to families, and we need to convey that to other people as well. And we know that addiction is associated with a range of problems. Dr. Tarter talked about some of those. And what's relative to today is on family functioning and stability. It has an adverse effect in many ways. And as he pointed out too, every family is not affected in the same way. or is every person. But nonetheless, we are affected when we have this problem within the family. Now, why do we have trouble helping families? One is, from the point, here, this from the client point of view. They feel guilty, they feel shameful. It's my problem. I don't want you involved. How many of you work in clinical settings? And how many of you have clients that don't want their families involved? That's a clinical issue. It's not a reason not to involve families. It's a clinical issue. Just like if someone is not motivated to change their drinking or drug use, it's a clinical issue. How do we raise the motivation level? And so there are other reasons as well. But I think clients in treatment fall to the lowest level of expectation. If you don't expect family involvement, you ain't going to get it. If you expect it, you're more likely to get it. You might have to negotiate and persuade, but you can do it. So here are some ways to do this. I can't tell you the number of assessments I've read, addiction assessments or psychiatric assessments, where there'll be a line or two about the family. Well, we need to get the information about the family history, including the impact on the family. So if you're doing a history of a client with an addiction, how's the family been affected? You need to get that information. Now, how many of you in medical settings? How many in medical settings here? A few of you? Same thing. You want to inquire about, is there family history? If you have a patient who may have a concern or say something about a loved one's drinking problem. So here's some ways of helping clients. The more you help clients, the more you can help families indirectly or directly. Directly if they get their family involved. We have to teach them about substance use in the family, how they affected the family. Now, do clients like to hear this, how they affected the family? No, it raises anxiety and guilt, but it should. If you're looking at how you hurt someone, you're not going to feel good. What are the benefits? But also, engage families or significant others when possible, and that could be by telephone or it could be in person. It could be an individual session with the family members, or it can be in groups, multiple family groups. Families often need other services for their loved one, because you talked about housing and transportation. You could throw in economics, you can throw in other things. And this is important. What's that bump? Expose clients to family members in recovery. Let them hear from families what it's been like for them, because they often don't have an idea what it's like for people who've been exposed to one's addiction. Now, the family, it's our fault. They feel guilty and shameful. I don't know how to help. I have many family members who feel hopeless, who feel frustration with relapses. I get calls all the time. I get calls and emails, usually from mothers, but sometimes from fathers. And usually if they email, it's at 2 o'clock in the morning. And they're despondent over their son or their daughter and their addiction. They want to know what to do. So they're frustrated. And if you look at the literature, when people in recovery do well, the family improves. When people in recovery relapse, it has an adverse effect on the family as well. And then how many of you have seen this? My son or daughter isn't serious about recovery. How many of you have seen that? I've been in the field for decades. I once had a patient who was serious. One time, no, actually, so the issue is, and this is why I think the whole movement of motivational interviewing is good, because we're looking at not having an interest in treatment is a clinical issue, not a reason not to help someone. If you look at the SAMHSA study, the annual study, about 11% get help, I mentioned. About 3% think they need help. So the typical, if there is such a thing, the typical person with a substance use disorder don't see they need help. And why is that? Well, one of the reasons is, if you look at their different levels of severity, if I have a drinking problem and I get drunk 50 times out of 100 times I drink, I may think, oh, I have a problem, it's not that bad. And so and I may think that, well, you told me I can't control my drinking. I don't get drunk all the time. So I may have a distorted view of my drinking and my problem. That's very common. Or, you're right. This heroin is not good, but what's wrong with smoking weed? These sorts of things, very common. So, oops, sorry. Here we go. I'm technologically deficient. When my son was 6 and my daughter was 2, if anything needed to be put together, he put it together for my daughter. So I think it's important to understand family pain. I think it's important to understand addiction from the inside out. What's it like to have an addiction? And what's it like to make a decision, I'll use drugs. I don't care what happens to my wife or my children or my grandchildren. What's it like for a family? What's it like for a spouse, a grandmother, a mother? What's it like for a child? Understanding addiction recovery through the child's eye. It's one of the few books out on children, the impact on children. So what I think is important, what I've learned over the years, is having a philosophy of care. What do we think about the family? Do we give lip service? Yeah, it's a family disease, but we don't do anything. And you don't have to see a family directly to have an impact. Part of it is, excuse me, how you deal with a client. But a family philosophy is important, just like a philosophy of care to people with substance use disorders. Outreach. If you don't outreach, you don't get them in. In the 1980s, Duncan Stanton, in the Philadelphia Child Guidance Clinic, they did a study of family treatment of heroin addiction. And there were a lot of young men. And they discovered if they didn't spend as much time engaging families and outreaching, then they wouldn't have had a clinical trial. You have to outreach. You have to be flexible. You have to have evening or weekend times that you can see families. It can't be at your convenience. Now, I used to be codependent, but I got rid of that term. There was a definition once, I read a definition. A woman said, a conservative estimate is 96% of people are codependent. And if you ever read a list of what codependency is, it's everything we do. So you want to be careful about labeling families as dysfunctional, sick, or codependent. I learned that from Dan Anderson at Hazleton when I went to one of his workshops decades ago. You want to view your family as the partner, your collaborators. You're working together. You need to work with them because they know more about the person than you do. You want to educate them. And very importantly, ladies and gentlemen, we have to sell hope. We have to convey hope. I hear it all the time where people they feel like this will never get any better. And you know what? It can get better. It can get better. So there was a family where severe alcoholism, I would say, I'm not good at math, probably 40 years of severe alcoholism and a history of psychiatric illness, depression, PTSD. And so if you look at the family, it was like, wow, this is, you would think this is hopeless. But guess what happened? At age 66, this guy got sober and lived for 14 years before he died sober. It was my father. So, and I'll admit at one time I felt hopeless. But back then, we didn't have systems of care like you have where you're offering services and doing things for people with problems and families. But we have to sell hope. If we don't have hope, ain't happening. So what I'll do is I'll give you some examples. A lot of what I do, we always incorporate the family. So we've done these Facebook Live telehealth townhalls. And so they used to do these by phone, and they did them on all kinds of health things. It could be hip replacement, the flu, all kinds of things. So we said, let's do some on addiction. And so my son, who works in social media, he said, why don't you do Facebook Live? I said, what the hell we need Facebook Live for? What is this bullshit? Well, what happened was, and we did 2 of them, and so about 500 or 600 people watch it live, but then it's archived, and then you pay so much money, and Facebook will keep it on. And there were the first one over 17,000 views, which is pretty good. The second one, there was fewer. But when we do something like we did one on prescription drug abuse and addiction, then we did one on alcohol use and alcohol problems, we always include a family component. So when you do education for the public or for patients or for colleagues, just add a family component. It's not that hard to do. Now, The Bridge to Hope, I love this title. I know the people that founded this. We have it at 4 locations at the University of Pittsburgh Medical Center. It's run by, the group is run by a professional, but it's a mutual support group. It's not a therapy group. However, the line between mutual support and therapy is awfully thin. Would you agree? It's very therapeutic. But what's important about this is that many things that we do, when we do, like we did a conference on pain and addiction last year, we involve families, and we get them to tell their stories, and we get them to participate in the planning. Dr. Flaherty and I were involved with a community program with the attorney. I always forget what Hickton was, the U.S. attorney? U.S. attorney in Western Pennsylvania, and they had family members on the panel, which was important. So we include them, and I was telling my colleagues last night at dinner, we started in the medical system what's called Addiction Recovery Grand Rounds, which is not easy to do, trust me, in medical systems. So we're in our 2nd year, and the 3rd program we did was on families. And we had people from Bridge to Hope come, the group leader and a husband and wife, very powerful stuff. But what we also did was we gave Narcan kits, and we gave them education. We brought in experts on Narcan from community agencies, and we bought Narcan kits for them. That's an important thing for families to know about. And I just saw an article in the paper the other day. In West Virginia, they have kids who are 7 or 8. They're teaching them how to use Narcan. But I think the point is that gives family a safety valve. They don't use them much, but having that makes them feel more comfortable. So the other thing I wanted to mention, which was very interesting, is we developed some educational programs for families, and they opened it up to the community as well, not just Bridge to Hope members. And we did Saturday programs. We did it for like 4 or 5 years in a row, for like half the day, like 9 to 1. And just basic education on substance use issues and what we're talking about. And then we added in recent years what I called Ask the Doctor. And I brought psychiatric residents, an addiction psychiatrist, and we broke groups into like 8 to 12, and each of them had a physician for an hour. And that was really powerful. But it takes you being able to get physicians to agree to do this, which can be done. But here's the most interesting thing. Mike, you did a Vigil to Hope, didn't you, a couple years ago for Bridge to Hope? So they have, every year they did a vigil for families that lost a loved one to an addiction. And they would have some presentations, they would have music, and there was a reception afterwards. You could put the photo up, you know, and then they had, you'd get a candle, and you go to the front. I light this candle in memory of so-and-so who I lost. So I've been to 3 of them, and the last one I went to, 131 people attended, 100 lit candles. One mother lost 2 adult sons. One man lost 2 brothers and a cousin. But this was the most heart-wrenching. A little boy, probably 9, his therapist brought him. I light this candle in memory of my dad who died when I was 3. That's the ugliness of addiction. People die and they leave family members behind. And that poor boy probably had no services. Now, years ago, Dr. Flaherty had the largest continuum of care in the Pittsburgh area. What he and his colleagues did was brilliant in terms of programs for pregnant mothers, adolescents, They had everything. And they had a program called CAPERS, which I can't remember what it stands for, but it was for kids who had a parent with an addiction. And Nancy Sarasa, one of your therapists, led the group, and these were, I think, between like 8 and 12, something like that. And they would use art, and they would talk about their experiences, and they would draw. And we actually have her on video showing some of the art and talking about it. And it's very instructive what the kids draw and what they say. But the one I remember most, and I don't remember the drawing, but I remember the little girl saying, "Mom hit me, she punched me, she slapped me. But the very worst thing is she died." People die from addiction. That's why everything we do is so important. Everything we do to stick with people and engage people is important. So, staff barriers. Okay, I'm a licensed social worker. I've had background in doing family therapy. You don't have to be a family therapist or a social worker to help a family. You could be any discipline. A 5-minute discussion, a 2-minute phone call. There are a lot of different ways you can help. So don't think it's someone else's responsibility and not yours to help a family. There's a lot of staff barriers. And what I have found, and we're currently working with some providers on increasing staff education and what's called value-based payment, where they get an incentive if they get all the staff trained or educated on family issues, and this is in rehab settings. So during the course of rehab, if there's 2 family contacts by phone or in person, they get an incentive. So we're starting modestly. So it's a nice project so far. We'll have to see what the outcomes are. But what I've been disturbed about, ladies and gentlemen, is I talk to different people in the community in different treatment programs. There's not much happening in terms of family services. And so I've called agencies just to check this out, or I've called helplines. And I called one, it's a 24/7 helpline, and they help you get treatment. They help you or your family get treatment for a loved one. So I said, my wife, she's got this serious drinking problem and cocaine problem, and she refuses help. She just won't get help. I need help for myself. So I was referred to go to the website and look for mental health providers. Now, do you think that was a good intervention? There's something wrong with that. And now I don't know if it would have like here in Ohio, but I can tell you, we don't have, the insurance companies have to change the methodology for payment so that you can get help as a family member, even if your loved one is not in treatment. The way it is now, if the person with the problem isn't in treatment, the family can't be in treatment. And there's something wrong with that. So these are just some staff barriers, but they can be changed. But I think of 3 things. Focusing on helping them change attitudes, educating them, knowledge, and then some basic skills. How do you engage families? How do you talk to your patients or your clients about families? Things like that. So I think we have to set expectations. We have to, I think all staff have to be educated. There's a difference between education and training, but if you have a clinical program, it would be good to have select people who can provide the evidence-based interventions, whether it's engagement or treatment. The other thing is, I can't tell you the number of case discussions I've heard in psychiatry, in addiction, clinical case discussions, where you discuss the case and the drugs and this and that, and not much is said or anything said about the family. There's something wrong with that. We have to include these in discussions. If you look at the ASAM criteria, the social environment's important. Dr. Tarter talked about the importance of the family and the social network. They should be included in these discussions. And then I think the other thing is, we found from a lot of our work is that families and staff like being connected to resources. There's a lot of good resources. And at the end of my presentation, I have a slide with just about eight websites you can go get good stuff on. But there's a lot of good resources, but people don't know they're out there. So, and they could be anything. They could be webinars, although the big thing now is podcasts. And I like podcasts because you can do them. I don't like them if they're more than a minute. Now I can go longer. I mean, some podcasts are like an hour and 15 minutes. They're too long. But you can do brief podcasts, and people will listen to them in the car, at home, you know, a lot of different ways of doing it. You don't need a computer. You could do it on your smartphone. So there are a lot of ways we can educate people, but we need multiple mechanisms to do it. And we also want to provide written information as well. And what you don't want to do is, there was a nurse, happened to be a daughter of a high-level person in the medical center who was admitted to a psychiatric hospital, dual diagnosis unit, addiction and mental health. And she wants to educate the mother, so she gives the mother an article on being codependent. Now, what do you think of that? She was insulted, which she should have been. You know, so, but there's a lot of ways we can give people information. And I think, too, in medical settings, when I go into my PCP office, I always look around. I'm like a neb nose. And what I find is that in the waiting room, usually you see the typical stuff: blood pressure, cholesterol, diabetes, maybe smoking. You don't see anything on alcohol and drug problems, or you don't see anything on the family. And then when you go into the treatment rooms, if you see anything on the family, usually it's a sticker, a phone number to get involved in a research project. So there are ways that we can provide information to people, but we got to promote it. We got to disseminate it. It doesn't do you any good if you don't disseminate the information. I mean, how many doctors and nurses, you know, they talk to you about this medicine, and then they go and they print this out. They give you these printouts. But you get a printout about family resources? You should, but you don't. What we did is we developed like a 10-page resource guide with brief descriptions and phone numbers and linkages to within our medical system, our community, federal, state, mutual support, and then a separate one on families. We have about 15 family resources. There are actually more. And people really find these helpful. That's something you want to think about. And that's not hard to do. You don't have to reinvent the wheel. And so some of this I already said, but many ways you can focus. I said we include families. We include family education, a lot of things. We provide naloxone kits. We had many presentations where we've given out naloxone kits. We facilitated family support groups. But what I wanted to point out, I wanted to talk about Dr. Tarter if I could. Now, Dr. Tarter is a genius, whether he recognizes it or not. And we've had many good discussions over coffee. We share ideas. And what I like about Ralph is that I call Ralph and say, Ralph, would you give this talk here? And he always does it. He always shares his knowledge. But what he's also done is we've written a couple chapters and papers together, which I think has been good because no one knows the impact of substance use disorders on children as much as Dr. Tarter. So this is just one example of collaborating with an expert and disseminating information. And what's important is, excuse me, I want to tell you two personal examples. In probably about 2015, Sage Publication came out with they organized a 7-volume set of clinical and abnormal psychology. It's really a nice set, and they're all brief chapters. So the editor sent me a note, and she said, would you write a chapter? And they had, like, if you took alcohol, there may have been 15 different topics. So I said, sure. And Dr. Tarter did some other ones for them as well. But there was nothing on the impact on families or the impact on children. So I said, can we include this? And she said, yeah. So we have 2 chapters that they normally wouldn't have had because we advocated. And that's one of the rules we want to take. We need to advocate for families. About a month ago, major publisher asked me, and I think probably Dr. Tarter gets these requests sometimes, to review a book proposal. And the book proposal had about 55 chapters. Anything over 54 is a little too long, you know? But it was phenomenal. It was really good. And so I had to, they asked me questions, and I had to, give a summary of my responses and everything. And so my response was simply, this is a terrific book proposal, but do not publish it if they don't include a chapter on the families. I was very direct, because how in the hell can you have a book and maybe you have 3 chapters on drug A, B, and C, which is important, not a damn thing about the family? Is there something wrong with that or what? Or am I just being a pain in the ass? Don't answer that. And so this is how I advocate for families, because I've been involved in too many planning groups where if I don't bring up the family or children, no one does. And so you can do that. You can be an advocate. So there are a lot of pathways to recovery. And when we talk about addiction, that's a more severe manifestation and more likely to need treatment. But less severe problems, people change on their own or with church. They do different ways. So we have to get away from there's only one path to recovery, which is treatment or 12-step programs or a combination. So there's really a lot of different methods to recovery. And there's a lot of evidence of positive outcomes. And I wanted to point out, so we have a lot of clinical trials and meta-analyses, but Mike did a brilliant paper on pathways to recovery where he interviewed extensively. Was there 7 people, Mike, or 6? 7 people. And he interviewed them and asked them questions about the recovery, and then he looked at what are some of the common themes. It's really a brilliant paper, and it goes to show you the importance of qualitative research, which really is lacking our field. But there's a lot of other evidence, too. The Faces and Voices of Recovery did surveys of life in recovery in the United States, and then it expanded to United Kingdom, Australia, Canada, South Africa. The membership surveys of AA and Al-Anon, all these show good outcomes for people who get involved. So this is the one I had mentioned before early on, over 22 million people, 9.1% of the adult population. This is a population health survey, no longer have a problem. And this is what they did. Less than half used professional treatment, small percent used medicine. Now this is community people, so you're not going to get the high rates of treatment or mutual support involvement as you would if you do surveys of people in recovery, because they're in recovery and probably going to using services. But what's important here is that about over a third had more than 5 years, and almost a third had more than 15 years. So you have some great data in terms of how long people are in recovery. This is very impressive. Why don't we hear about this? We need to promote this stuff. And when I give talks, I still run groups, recovery groups for patients. I share some of this. Then we talk about, well, how do you think they did it? We talk about the different methods people can use for recovery. And then for less severe problems, you have self-recovery. People can do it on their own. And sometimes, I've known people with severe addictions who did stop on their own, too. So sometimes that does happen. So this is the U.S. survey I just wanted to mention. And so recovery is associated with dramatic improvements, and they usually accrue over time. It doesn't happen overnight. And I'd mentioned there's other countries. But it's good for everyone. And what it's good for is the family, and an area we don't think much about is the economy. Because people are more likely to work, vote, and I like this one, pay taxes. Pay taxes. Because these are things you don't think about, but when people in addiction, they often don't pay taxes. Now, my dad, I'll tell you a quick story about him. Excuse me. So I grew up in Johnstown, and if you know anything about Johnstown, they're famous for floods. Well, he was a plasterer. He had his own business because he kept getting fired. And if he'd get paid, he'd just get paid and spend the money. So the IRS in the 1970s said, well, Mr. Daley, we would like to talk to you. And they were ready to bust him. And then we had the Johnstown flood, the flood in the 1970s, and they gave him amnesty, so he was lucky. But here's someone that just, he worked and never paid taxes. And that's not too unusual, but when people get in recovery, often they do. So life in recovery you have, and what's really good is, excuse me, I have a zillion slides where I showed during active addiction and recovery the improvements in all these different areas. So, for example, if you look at the first one, you have a significant increase in people, 120% increase in people getting a dental evaluation. You have about a 200% increase in people seeing a PCP or seeing a physician. This is really good. You have 125% of people exercising. So every one of these areas, you have significant improvements as people continue in recovery over time. And in family relationships, which is really the theme here, family relationships. So what they found here is they do more activities together, which is good. This is very significant, and Al-Anon found this too with different data, big decrease in violence, mainly being the victim, but sometimes being the perpetrator. So there's less family violence, and there's more family cohesion because you don't lose kids or you get your kids back. But there are other benefits too that just aren't documented in these surveys. So a lot of good things do happen. So that's life in recovery is very important. So you may want to check these out because I think what they show, they counteract this belief that people don't get well or we have multiple relapses. Even though people may have recurrences, people get well. In fact, if you have major depressive illness, you have a 50% chance of a recurrence. If you have a second recurrence, you have a 70% chance of a third recurrence. And if you have a third, you have a 90% chance. So major depressive illness is a recurrent condition. So we don't judge people with major depression. We say, if they don't respond to treatment, we say, well, they're refractory. Let's find a treatment that works. With addiction, they get the finger of the judgment. And then here's a survey of families in the United Kingdom. Same thing. You see all these different areas improve. And what some of the other surveys show is that when family members engage in recovery, they do better at work. They don't miss as much work. They get better evaluations. They don't get fired as often. So these are good. A lot of good things happen. Okay. So just take a minute at your table. Actually, stand up for a second. Let's just stretch. I can't sit down for more than 10 minutes. Okay, so you can do this standing up or sitting down. So if you think about the impact on the family, just share one example in your table from each of you, just one thing that stood out to you in terms of how families are affected. So what are some examples of how the family's impacted? Economically, and what that would mean is, and that may be related to suspensions, loss of job, underemployment, depending on welfare, all these things. And if you look at men versus women with addiction, women have higher rates of poverty. And if you grew up poor, it sucks. Okay, so economically, what's another example? Yes? Fear. Yeah, fear. We did a survey, one of the members of the Bridge to Hope and I did a survey of parents a number of years ago. And their number one fear was losing their son or daughter to an overdose. Their second fear was relapse. And the third was them being able to function. But the fear can also be fear of safety. fear of safety. There was I can't remember his name, but it was a Sports Illustrated article where there was a fighter who had a severe addiction problem and would beat up the violence was horrible, and living in fear is just awful. One other example? Isolation, family isolation, yeah, absolutely. Okay, and so we'll talk about some of this. So here's my dad, who was a machine gunner in the Pacific, who got the Purple Heart, who had severe alcoholism, severe depression, anxiety, got sober at age 66 and died sober, which is good. And how he got sober was he did all the traditional stuff and went to rehab and left. And he was, I was told that he got thirsty. Now, God forbid a person with an alcohol dependence would get thirsty for alcohol. My God, how in the hell could they do that? But what happened was, actually, a couple things I'll mention. One is, I think there was a lack of awareness of the psychiatric comorbidity, because I know he had PTSD and he had depression and anxiety. But the other thing is, now think about this. This is a 66-year-old guy he would be in his 90s now. He's in treatment, and a young clinician says, he finds out that, he lost his wife. My mother died in 1988 of cancer. And the clinician says to my dad, write a letter to your wife. And what do you think he said? She's dead. So it's an example of someone trying to use a technique that's not relevant to the relationship with the individual person. So we lived in the left-hand side, and this is not unique to us. We had all that negative stuff. And then the Daleys kept a lot of people employed in the social service and the legal system, so you can thank us for having jobs. But I think what's important here is you have all this negative stuff, but you also have resilience, motivational, and survival skills. You had family members do well with their recovery, not all of them. Family members do well, just did well in life. They had their struggles, we had our struggles, but we did well in life. It wasn't linear, it was smooth. So we don't always want to think about the negative, we want to think about the strengths and the resilience as well. And Dr. Tarter talked about the importance of resilience. So these are just some of the impacts on me. Just one thing, two things I want to mention, one on each side, was, and we don't, the thing I have on the left underlined, what I learned from my father is what not to do. I didn't know how to fix anything. I didn't know how to do a checking account. I didn't know nothing. I was like life illiterate. And I left home at 17 after I graduated from high school to go work. And I worked for a couple of years before I went into the military. And then I had to learn all that stuff. Now, on the other side, I will mention, I think, a significant experience that may have been the saving grace for me, which is doing horrible in high school, and a guidance counselor calling me in and said, Dennis, you should be doing better. We have this program I want to recommend to you. It's called Upward Bound. How many of you have ever heard of Upward Bound? Well, I went to the first program in 1966, and it turned me around academically. I went from a D student to a C student. That's a pretty good boost up. And then when I'm trying to get out of the Army early, all the schools I applied to rejected me because my academic record sucked, so I had to start with a community college. But nonetheless, what it did is it was an intervention where someone saw a child who wasn't doing well. Now, she had no idea this was anything related to the addiction in the family. It could happen even without the addiction, but she did something that made a difference. And those things happen a lot. So same house, different home. Dr. Tarter had mentioned everyone's not affected the same. Positive or negative effects, more harmful for some. I had a family, very educated man. His 13-year-old daughter was resilient. She had joie de vivre. She was academically great, athletically, artistically. She was involved in lots of stuff. The 10-year-old son was depressed. Same house, different home. So it's more harmful. And then a lot of offsetting factors as well, including the resiliency factors. So now, negative emotional distress, you had said fear, but these are some other things as well. And I think what we hear a lot about is the chronic stress, that it just feels awful. It just feels awful. So all these things are common. And actually, if you look at anger and resentment, there's I just read this in the new book on the family guide that we have out there. I think on page 2 or 3, give an example of a father who says to his son, "Get your Social Security tattooed on your arm so when you die of an overdose, we can identify you." And then I heard a story a week ago, and I can't remember who told it to me. It was a father in recovery talking about another father in recovery, where the one son died and he has the urn. Let's say it's above the fireplace, and the other son's still addicted, and he says to his son, "That's where your urn's going to go." And what these guys are saying is they're in deep emotional distress. So it's a central focus of the family, high rates of separation and divorce. And this is important too. Grief. We grieve the person we lose to the addiction, but they die. Kids may die too. Innocent kids may die. They get incarcerated. But we have all these other losses as well. We have loss of stability in housing or emotional stability. So there's a lot of losses that are associated with addiction or made worse. So we want to be aware of this. High rates of violence, which we had mentioned before. Less cohesion, more conflict. Family rituals. We never took family vacations. I had mentioned my loss of my wife of 30 years, but I tell you what, I give her a lot of credit because when I got married to her, her family was lovey-dovey. I thought, what is this shit, man? But I like it. Now I hug anyone, I'll go to the grocery store and hug the person who checks me out. So that was important, to learn that connection and the affection, but also the family vacations. We never took a vacation. I didn't know what a vacation was. And my wife, she loved vacations, and she planned them, and we would take them regularly. At first it was like, this is kind of weird. And actually, one of the things that we did as kids, the only thing we did as a family is in the summertime, sometimes we went to a park on a Sunday where you could swim and barbecue and maybe throw the baseball around. And when I think about this, I wonder how this happened. And let's say, for discussions, we did this 50 times over a couple years. Every time we left, my dad was drunk, 8 people in a car, no seatbelts, we never wrecked. There must be angels. Must be those Irish angels, Michael. Your risk goes up if bad stuff happening. So, but the family vacations, and then in our family, and some of this comes from my own experience, is that there was no involvement in any academic or athletic activities. Oh, you had, Dr. Tarter had shared a slide about Michael Jordan. Who's a basketball aficionado in here? Anyone like basketball? Well, I have to disagree with that slide. So Michael Jordan talked about missing. Now, I don't want to brag or anything, but I do have to tell you, I still play basketball, and I'm undefeated in the last 5 years. Undefeated. You impressed? Now, do you want to hear who I beat? 2-year-olds and 3-year-olds. I dunk over them, man. Those 4-foot baskets. You ain't getting in my way. Now, I don't know. I have no idea how this happened. But when my first grandson was born, when I went back, he was born in the evening, and I went back in the morning with a gift. I took him a basketball. I have no idea why I did that, but all the kids now, when they're born, They get the 3 Bs. They get books, a basketball, and a bank account. But they all have little basketballs. And actually, it's kind of cool because most of them like basketball. And they talk about it. In fact, my 3-year-old, actually when she was 2, she was out at Target with her father, and she bought me a basketball for Christmas, which I thought was really cool. So I expect probably within the next few years I'll lose my first game. Okay, Dr. Tarter had talked about that. So now I want to talk about, some of this I've already talked about, but we have to educate, we have to advocate because families don't have people advocating for them. So anything you can do to advocate for them, you know, within your system, within the community, we can facilitate. I happen to think, I've been in the field for decades, like Dr. Flaherty, and we've done a lot of things to make a difference, but we know a lot of staff have. So if you go back to the program I had mentioned, the Capers program, he had a young staff member who wanted to do this group for kids and did this wonderful art therapy group for kids affected by parental addiction. I think good things happen because of people like you. You know, and it doesn't matter. It can be in a clinical setting. It could be in the recovery the community. It can be anywhere. There's a lot of things you can do. Screen for the impact of substance use disorder on the family itself. Knowing how to engage people in treatment. That's a big issue, but there are ways of engaging people. Grief interventions are very helpful, involving the family in assessment or treatment. So I was on the way in the car yesterday, on the way up, I got a call from someone. I'm working with a family that I get referrals from colleagues, and they were asking for help getting him in treatment. So we had this discussion about him going to treatment, or going for an assessment to determine treatment. And what I suggested is he take his wife with him. He wasn't even thinking about that. Take your wife with you. That's going to be important. And you may want to think about, and I think part of Dr. Flaherty's work with the community is how can you expand or develop your services? And that includes services for families. Because the more you help them, the more you can help people, you know, with the addictions. Now, here's an example I just wanted to mention. So I don't know your insurance companies, if they have wellness programs. Do they have wellness programs and coaches? Does anyone know? So UPMC, they have chronic conditions. Then they have lifestyle things. Lifestyle things might be exercise and diet and smoking. And they have coaches they can refer you to. A PCP, a nurse practitioner, physician assistant can write a script. And if you write a script, someone's more likely to follow through with it. And the script is to see a coach or talk to a coach by phone. And they can talk to you. So we developed this thing, Prescription for Wellness, Support, Hope, Recovery for Alcohol or Drug Problems. And what we wanted to do is have medical professionals let people know that we can help you or we can help your loved one. And I don't have any data. I don't know how it's going so far, but it's a step in the right direction. And then what we did was the coaches use handouts all the time. It might be on blood pressure. It might be on diabetes management. And we did 20 handouts on substance-related issues and depression. And they're 2 to 4 pages, and several on the family, what the family can do. And then they have all these self-care guides for everything for diabetes. They have it for smoking cessation and other conditions. And we did 2 on substance use, 1 for someone with a problem, but we did 1 for the families as well. Now, I won't bore you with the details of how hard it was to get these done, but suffice it to say that we advocated for something for families, and it was done. So these are just resources that are important. Now, if you look at the science, there's a lot of efficacy studies. So there are therapies that are couples and marital therapies that are effective, and these are some. Different names. They all have evidence to them, so that's good. And the one thing I would say, I forget, this afternoon there's one on craft. Is it Amber who's doing craft? Is that you? And this is an example. I haven't even met you, but I love you. This is an example of someone who takes these models of treatment, and if my understanding is right, you're teaching people in the community to use this craft, correct? Okay. And I have a friend that did the family survey with me. She's doing it for church members in her community, same thing. And, teach them how to use it to get their loved ones in treatment. But the beauty of the craft model is that even if you don't get your loved one in treatment or recovery, you get help for yourself. That's the important thing. You get help for yourself. So, now unfortunately, when we did surveys of professionals, you have low, I don't know what it's like here, but low rates of understanding or being aware of craft, which is really a shame. So these are just some of the outcomes. So if you look at a lot of the family interventions, they get people in treatment. The retention completion rates are higher. There's better rates of stopping or reducing drug and alcohol use. Relapses are less severe. Domestic violence, there's all kinds of good improvements. And so the person with the problem improves, but so does the family member. And these are the adolescent studies. They also do better academically, and they get in trouble less. They don't get in fights as much, those sorts of things. And then when you look at family members, they feel better. They have less anger. They have less depression. They have less anxiety. They get along better. They communicate better. And some of this is, the focus of treatment, but these are good outcomes too. And so, we have good evidence that these treatments make a difference. We just have to use them more. So if you look at families, a couple comments of what I think they need. Excuse me. Number one is understanding addiction from the inside out, because they think it's bad behavior. Why are you doing this? They think it's bad behavior, or they think, you're scamming. They don't realize that you're so addicted that you just want to feel normal. You don't want to go through withdrawal. So teaching families about addiction in the brain. So when you have educational programs, you can show them parts of the brain and discuss some of the impact and how that affects someone with an addiction. Help them understand obsessions and compulsions and cravings. I actually have a intervention I've used with a lot of people over the years from the Big Book of Alcoholics Anonymous. On pages 30 and 37 and 38, there's a jaywalker analogy. How many of you are familiar with the jaywalker analogy? You read that's brilliant, in discussing obsessions and compulsions. It's a great example. So we have to help people understand this, and they can make better decisions. Acknowledging the impact, and there's two sides of this because, families they cope well. Some of them cope well, and some of them are very resilient. Although we do know we have these adverse effects we had mentioned. And then this is important too. It's not personal, but it feels personal. But part of it too depends on, does that person still live with you? So if your adult son or daughter still lives with you and they're actively addicted, that's different than, excuse me, if they live in another state. You're still distressed, and you still have these adverse emotions, these negative emotions, but you're not affected day to day as you would be if they lived with you. So this is just some of the areas that they have to understand, I think. And I think too, we told you about those family programs we had done, that families really like hearing this stuff from professionals, but they also like hearing stories of families in recovery. This is a hard thing to do at first. At first, people want to focus on my loved one, getting them in treatment. But this is focusing on yourself. What do you need for yourself? And when we interviewed people from the Bridge to Hope groups, I've done focus groups, and you could see over time when people first start, it's like, oh, how do I help my husband? How do I help my wife or my son? But over time, as they get integrated, they start focusing on, okay, I love my son or my husband or my wife or my daughter, And I may be able to influence them, but maybe not. So what do I do for myself? What do I do for me? That's the focus on self-care. And you're going to have people, it's not unusual. I've seen this with many couples I've seen where the spouse has a clinical depression, needs help for the clinical depression. And so, linking them or referring them to get help for the clinical depression is important as well. The other thing is, how many of you have seen where a family sends someone to rehab, the family's on cloud 9, like this is it. This is like, the life's going to turn around. Have you seen that? Anyone seen that? Does that ever happen? No, you come back to the real world, you have all these challenges facing you. You have drug cravings. You have pressures from others to drink. You have boredom with recovery. You have upset emotions. Dr. Tarter talked about, negative emotions, how people use to feel better. You have all kinds of things happening. And what I've heard with the opioid epidemic, there has been a big focus on, we need more rehab beds. And maybe it's true, but I would say, okay, Jesus could come down and give us 1 million beds, but what happens when 1 million people leave rehab? They have to focus on recovery. This is why the community is so important. And we also know that long-term involvement, continuing care is important as well. We have that with mental illness. We have that less with addiction. With addiction, we rely pretty much on 12-step program or mutual support, which is good, but we also need long-term professional treatment as well. And Mike and I have talked about this many times, where most of the money goes to the acute phase of treatment, detox, rehab, maybe intensive outpatient. We need long-term involvement. If you have recurrent major depression or schizophrenia, you can stay involved for a long time. Usually addiction, you're out within 6 months. So focusing on self, the support programs, it could be Al-Anon, it could be Nar-Anon. If you have favorite programs in your community, they've started, this is amazing, in Western Pennsylvania, a number of people have started programs. Bridge to Hope is one. But I had, Mike, do you know about Sage's Army? I don't remember if I had breakfast with the guy that founded this. 8 years ago, his son died from an overdose. His name was Sage. And so for 7.5 years, they had a group of volunteers. They would raise money with donations, shoestring budget, and they would help people with addiction and families. And they did support groups in the community. And they just got a state grant for $500,000 to offer services, which is really, really good. But the commitment and passion is second to none. There's another group, there's a favorite group. It spun off from a group called My New Leaf, and now it's part of the Faces and Voices of Recovery. And they have an old church the woman bought, and in the basement is a large area, and they have recovery meetings for individuals and for families. And one of the unique features of the recovery meetings is they have, some are for people with addiction, some are for families, but some are what's called all recovery. Anyone concerned about an addiction can come to the program, and then people get support and help from each other. Now, the program I visited, this was very interesting. In South Carolina, they had recovery coaches, half were for families and half were for people with addiction. And when they'd have these meetings, they sent a clipboard around, and it said, if you want a coach to call you, give us your first name and your phone number. And so you could come to the meeting, that's it, or you can come to the meeting and get a coach to follow up with you, which is a great example of people in recovery helping other people. Now, how many of you have seen reports on the opiate epidemic from like the government, like the Surgeon General, or SAMHSA, or Harvard, or Johns Hopkins? How many of you read them? You don't have to tell me. I know you read them. That's why I love you. You're conscientious. You're very good. So I paid attention to these reports, And I looked at a lot of them in detail. And I can tell you, ladies and gentlemen, they will tell you all kinds of information about things like fentanyl and carfentanil and the importance of buprenorphine and warm handoffs. That's good stuff. But they don't have much about the family and nothing about the children. The Surgeon General's report didn't say anything about children. Now, how the hell can you be Surgeon General of the United States and be concerned with the nation's health and be concerned with the opioid epidemic and not be concerned with children? I don't get it. But I think that's why I'm urging you to think more broadly. When you think of families, which you do, think that families have children. Children are affected. And I think it was a Harvard study they found, actually it's a good paper, I actually have the paper here, but there's over 10 million kids in families who are affected by parental addiction. That's a lot of kids. That's a lot of kids. But these are just some things. But I think two things that stand out for me, from my experience clinically, is one is if these kids have a problem, help the family get help for them. You know, maybe the kid needs help with depression or academic help or that sort of thing. I think that's very important. But the other thing is, if you're a clinician, you might want to bring in the child in the session, you know, and just get a sense from him or her what it's like for them. But children, you know, it's amazing. Children are affected, and we have to keep that in mind. And the other thing is, so how many, in the past year, how many webinars have you seen advertised on the opioid epidemic or addiction? Mainly the opioid epidemic, but maybe addiction. How many? A lot of them? Okay. How many conferences have you seen advertised on addiction or opioid addiction? Many conferences, right? Okay. Now, if you look at these webinars, and if you look at these conferences, and you probably looked at the details, how many had a session on the impact of opioid addiction on children? No? Did anyone see anything? I've seen one webinar in the past 4 years that focused on children. It was from Hazleton. It was from the picture of the book I had, Jerry Moe. It was his webinar, you know, because he works with children in children programming. We were trying to bring him to our summer conference this year, but couldn't get him because of the timing. But I think the reason I raised that, just like the issue of, you know, the writings about addiction and treatment that don't focus on children as well. It's a bullshit detector. I thought I had that. And then the last thing I just wanted to mention briefly is I want to tell you about, I thought I had this turned off. I know a name that's never good. You know what they do? That's a robocall. Do you ever get these calls for like they want to know your mortgage? Anyone ever get those? So I'm in the car one day, and I said, okay. So the guy calls about, I want to offer me a mortgage. I said, yeah, I'm real interested. He says, well, how much do you owe on your mortgage? I said, I owe $1.2 million. And he says, how's your credit? I said, it's pretty bad. So I went through about 5 questions when he figured out I was bullshitting him, and then he hung up. Now I don't even answer him. So I just wanted to tell you some incredible stories of resilience, which just moves me to no end, because I see this all the time, and I think this is important. I think this is just as important as the science of addiction and treatment and recovery, which is the human element. So someone I'd known for years but never met in person, when she was in summer vacation, in front of her, a drunk driver killed her 61-year-old mother and 6-year-old daughter. And so she wrote a book about her daughter called Kendra, beautiful thing with a spiritual component. Really, really amazing. a football player at Pitt decided, he got drunk and decided in 2 o'clock in the morning he wanted to ring the church bell. If you've ever been in a Catholic church, you know, they're very high. And he was walking along the ledge, and there was a guy behind him. And this was, remember, this was 2 o'clock in the morning. So he's walking along the ledge, and all of a sudden, the guy behind him says, "Billy, let's go back." And as soon as he said that, there was a thump. He saw a light. He fell through the ceiling, hit his head on a pew, and died at Mercy Hospital 2 days later. And he was if he was your son, you would be proud. He was a great young man. One drunken episode can do this. And his dad wrote a book called Blood on the Pew, and just amazing story. And then I have a couple friends who lost sons to overdose. I told you about Sage's Army with Carmen. But I know a woman, and you know her, Lucy, I won't mention her last name. She started 3 treatment agencies because of her loss of her son. It was just amazing. What they do is they take their heartache and heartbreak, and what they do is they do something about it. And then, because everything's not heartache, you also have people, loved ones who have people doing well in recovery. So we have a whole cadre of people we call on, and they do the workshops with us and the education with us and the webinars. Last week, I had a guy share his story as a father, and it was just really powerful. And I think that's helpful, you know, getting families involved. So these are just some resources. I think you have access to the presentation. So these are just some of the resources that are very good and can make a difference. But I would just end by saying, what we do makes a difference, and what we do is important. And your work in helping people with addiction and families, I think from talking with Dr. Flaherty and looking at some of the information, you guys are ahead of other communities. It's very impressive to me. You just need to continue building on that. And you want to include, you always want to include the family perspective, and you want to include, you know, you want to think about the children as well, because we can make a difference. So anyways, well, I thank you for your kind attention, and I'll be around if you have any questions. We have an question and answer session this afternoon, but over break if you have something you want to say. But thank you for your attention. I appreciate it, and thanks for the offer.